Take ourselves out.
And I'll share the screen after you've introduced you.
So welcome everyone. I'll just give you a chance to log in before we make a start. Numbers ticking up. I'll just give it a few more minutes because I know there's quite a few more people logged on, but it may be that they're planning on listening to it later. So how are we doing? Doesn't look like the numbers are chucking up anymore at the moment, so perhaps we'll make a start. So kia ora everybody, I'll just introduce myself. I'm Jane Morfitt, I'm the Clinical COVID Education Manager, and it's my pleasure this evening to introduce you to the person that, those of you that know the Immunisation Advisory Centre really doesn't need any introduction, our Medical Director Nikki Turner, who's also Associate Professor at Otago University, and somehow she manages to find time to be a GP in amongst all the other committees that she sits on. So I'm very happy to have you with us tonight, Nikki, and we'll hand over to you. We've got Loretta Roberts sitting at the top there, and myself. Loretta is our manager, and we will be sitting in the background supporting Nikki with questions. Just before I hand over to her, a little bit of housekeeping. If you could type any questions that you've got into the Q&A box at the bottom. And the chat function has been disabled. So if you put any questions or comments into the Q&A button, then we can respond to them and answer questions either directly via text to you, or probably most of the questions will be answered live once Nikki's finished her talk. I think I've covered everything. So I'll pass over to Nikki and we'll hide ourselves from view for a bit.
Thanks very much, Jane, and kia ora koutou to everyone on the end of the screen. Oops, I'm just going to screen share now. Oops, new share. Hang on a moment, folks. We're coming up with the right one. So we're just going to, I'm just going to go through a bit of the recent data we've got around particularly the COVID vaccine in New Zealand, the Pfizer vaccine. So what we're just going to look at is we're going to touch on COVID, the effect of COVID in pregnancy, talk about the Pfizer vaccine, the use of the Pfizer vaccine in pregnancy, the data we have to date on safety, what do some other countries advise, and then touch on breastfeeding and touch on mammography, and then just see what other questions people might have after that. And I want to acknowledge that a lot of the material in this comes from a literature review done very recently by Dr. Mary Nolan, who works in the Immunisation Advisory Centre for us, and many other members of the Immunisation Advisory Centre who've helped with various slides along the way. So look, the starting point to why we would consider the importance of COVID vaccinations in pregnancy is, as everybody knows, we're in an appalling situation internationally in the world at the moment, that COVID cases are rising around the world, and many countries are in a really significant problem. And even though, as this suggests, that we've got more than 140 million cases and more than 3 million deaths, this is a significant undercount. So, you know, even the current counting, about 1.2% of the world's population have or have had COVID disease, and that may well be an underestimate by anywhere up to 10 or 20%. So we're really in a critical position in the world. We know that COVID vaccines are going to play a really important role, not the only role, but an important role in helping us manage going forward. So that's the background to why we need to consider quite urgently the role of COVID vaccine in COVID disease and pregnancy. So first focus is the disease itself. Is COVID disease a problem in pregnancy? Now, you know, the data is accumulating all the time, but we do know in general that respiratory illnesses are often more severe in pregnancy. We know that with flu vaccine, We know it with many other respiratory viruses. So what we do know is the pregnant immune system is downregulated so that immune system doesn't kill off the fetus. It has to be downregulated to prevent immune response to fetal antigens. Now, as a result of downregulating, the immune response to viral infections is not always so vigorous. So therefore, pregnancy is a time of higher risk of viral infections. And we know that from flu and varicella. We now have a lot of accumulated data that pregnancy also, if you get COVID and you tend to get it more severely. So COVID in pregnancy, there is not an increased risk of catching it, but if you do catch it, there is an increase in severe disease. And what we have from research is that ICU admissions are 18 times higher than comparable non-pregnant women. Death rates are 3 times higher than non-pregnant women who are comparable. The risk increases if you've got increased maternal age, higher BMIs, or pre-existing comorbidities. So very similar to the pattern we see with flu. And a UK study showed that there is increase in intervention at birth, more likely ending up with cesarean sections, and there's more likely to be preterm births, and that's owing to the fact that you've got maternal respiratory compromise. So you're having 10 times as high preterm births in severe versus mild disease. So basically, COVID is not a disease you want to catch in pregnancy. Is it a problem for the newborn? Not to the same degree. There's an increased risk of preterm, and there's an increased risk of neonatal ICU admissions. But other than that, COVID disease does not affect fetal growth. It doesn't affect other neonatal outcomes or stillbirth rates. The transmission from the mother to the newborn is at quite low rates and rare. And most transmission, as you can see there, is mild or moderate. So the real message is COVID disease is very nasty for the pregnant woman. The outcome for the infant is really the increased incidence of preterm and the problems that comes with being preterm. So those are the major consequences of having COVID in pregnancy. So very strong reasons for the world saying we don't want pregnant women to catch COVID disease. So therefore we should be thinking strongly about how to protect our pregnant women. So how are we going to do that with vaccines? Well, as we're all aware, New Zealand now, the only vaccine available to us currently is the mRNA vaccine Community by Pfizer-BioNTech. How does this vaccine work? Now, it's really important for us to have a bit of an understanding of how this vaccine works, so therefore we can be comfortable with its use in pregnancy. Now, essentially, the RNA is the template that is injected into the cell. So you inject the RNA into the cell. It's the cell itself that makes the proteins. The body's immune system recognizes the proteins as if they're the spike protein on the virus, and they make immune response to the proteins. Now, the important message about this is that the body does not have, the vaccine does not contain any piece at all of the COVID virus. It's not a live vaccine. It's not even a piece of a virus. So it's a template, an RNA template for the body to make the spike protein. Now, first important is it's not a live vaccine. The second important message is this is RNA. It is not DNA. So it doesn't enter the nucleus of the cell. It cannot alter the genome of the cell. And once the RNA is taken up into the cells, the proteins are made, the RNA is broken up very fast. So it does not hang around for very long. So that's a picture for those of you who may not have seen it before of the RNA, the piece of RNA that codes for the protein that makes the spike protein. It's coated in a little lipid bubble. The lipid bubble is what stabilizes the RNA long enough for the body cells to respond to it. The body makes the proteins, and the immune system, this is a dendritic cell, picks up the proteins and then makes the immune response. A very beautiful technology for a vaccine. We all are aware it's a 2-dose schedule, 3 weeks apart. Now, the other important thing about this vaccine is it's not live. It doesn't have any virus within it. And actually, there's not a lot in it. It's actually a very purified vaccine. So the active ingredient is the messenger RNA. It's coated within the fat coat. The fat coat is to stabilize it. Then they add some salts in it so that the pH matches the pH of the cell. And then there is some sugar added, and the sugar is to ensure that it's stable at the very cold temperatures. Now, essentially, this is a list of all the products in this vaccine. It's very limited. So it's a vaccine that doesn't have a lot in it. So very few people have severe allergic reactions to it because there's not a lot in it, okay? So it's really useful to know what's in the vaccine. Now, the role of these vaccines in pregnancy, can we use them in pregnancy? Well, firstly, there is no theoretical concern about mRNA vaccines in pregnancy for the mother's safety or the fetus safety. They're not live vaccines. They cannot give the disease. They cannot enter the cell nucleus nor interact with any genetic material. And the actual code is rapidly broken down after entering the cell. So there's no specific safety reasons to exclude pregnant women from using these vaccines. The preclinical trials also did look at pregnant animals, and there were no concerns there. But pregnant women were not included in the original randomized control trials. Now, I think that's really disappointing, and it has held us back a bit. The reason they weren't included is really in the early days, they weren't aware that pregnant women were at high risk. They were doing the randomized control trials as rapidly as they could. And pharmaceutical industry is always worried about medico-legal issues. So clinical trials and vaccines have traditionally left off pregnant women in the first randomized control trials. Now, I think that's very disappointing because there was no reason to leave pregnant women out. So we did not have any early clinical trial data on pregnant women. However, the advantage for us now is once this vaccine was approved and used in many countries, it has been used extensively since late last year, and there is now quite a lot of mounting post-licensure data. And so I'm going to present the mounting post-licensure data now. So what we have got is, particularly in the States, quite a large cohort of data now, which has been collected through the US CDC, through their traditional VIAs collection reporting mechanism called vSafe. Now, up to May the 17th, there is well over 110,000 self-reported pregnant people on that reporting database. Now, there's a subgroup of those who have been followed up closely in a smartphone-based reporting system, 36,000, which is a very big number. And then there's another number called the vSafe Pregnancy Register, which is nearly 5,000 women who are being followed up all the way through their pregnancy, right till 3 months after the infant's born. Now, the data on those numbers to date is looking great. And I did want to point out in that vSafe group of 36,000 that about 5,000 of those were women who fell pregnant after being vaccinated. So you've got the useful group of people who were vaccinated after being pregnant, but also vaccinated and then fell pregnant. So what we can say from that data is the reactogenicity adverse event profile does not suggest any safety concerns. There was no increased risk of the major issues, which includes miscarriage, fetal loss, small for gestational age, and neonatal outcomes. So the data is looking really positive based on this very large American study. It's interesting that other vaccines that we've used traditionally in pregnancy do not come with this amount of data. So already we've accumulated more data than we have for many of our traditional vaccines. So this is some really interesting data looking at pregnant women matched with non-pregnant women being given the Pfizer vaccine and the two RNA vaccines in the States. One is our Pfizer vaccine and the other is the Moderna. And so looking at giving these vaccines to women in pregnancy or not in pregnancy, are you seeing any difference? And essentially, you're not really seeing any difference. That the pregnant woman's safety profile is looking the same as the non-pregnant. So that's really nice data. There are other observational studies underway in other parts of the world. So I just highlight that further data is coming, that there's been over 270 million doses of COVID vaccine used internationally. of which 144 million are Pfizer and 115 million are Moderna. So that's extraordinary numbers being given out there. So, this is absolutely not an experimental vaccine before. This is a hugely well-used vaccine. The UK is also monitoring their COVID vaccination given in pregnancy, and they also, to date, have no concerns with their data. So based on that data, recognizing we didn't have original clinical trials, but we've now got tens of thousands of women in these studies, and it's looking really reassuring. What are the international recommendations? So firstly, from the States, the American CDC advice, which has been updated just last week, is making the point that pregnant people are more likely to get severely ill with this disease compared to non-pregnant. So they recommend if you are pregnant, you can receive a COVID vaccine, and getting a COVID vaccine during pregnancy is expected to protect you from severe illness. The American College of Obstetricians and Gynecologists recommend directly pregnant individuals should have access to COVID vaccines, and they also recommend that breastfeeding women should be offered vaccination. They note that while a conversation with a clinician may be helpful, it should not be required prior to vaccination, as this may cause unnecessary barriers to access. They're essentially saying in the States, pregnant women are at risk of COVID and can safely have vaccination. What do the Canadians say? The Canadians' consensus statement that has been updated early May recommends that pregnant women should be offered vaccination at any time during pregnancy or while breastfeeding if no contraindications exist. And those contraindications are the same contraindications across anyone being offered COVID vaccine, which would be acutely unwell on the day or a history of an anaphylactic event to a previous dose or a component of the vaccine. I note point number 5, that given that pregnant people are at increased risk of morbidity from COVID infection, all pregnant persons should be eligible to receive a COVID vaccination. Obviously, these countries are in a position that we fortunately are not, that they have widespread COVID disease in their communities. The UK advice, which has been updated from Public Health England on the 30th of April, says that COVID vaccines available in the UK have shown to be effective and have good safety profiles. These vaccines do not contain live virus, cannot infect a pregnant woman or her unborn baby in the womb. There is no known risk with giving an activated virus or bacterial vaccines or toxoids during pregnancy or while breastfeeding. The JCVI, which is the advisory committee in the UK, has advised that pregnant women should be offered COVID vaccine at the same time as people of the same age group or risk. So they are now recommending pregnant women routinely receive the vaccine when it's appropriate to receive it. The Royal College of Obstetricians and Gynecologists in the UK are saying very similar advice. You should not stop breastfeeding in order to be vaccinated. Women trying to become pregnant do not need to avoid pregnancy after vaccination. There is no evidence suggests COVID vaccines affect fertility. Now, just out of interest for people, the UK have a decision aid for clinicians if they want to sit working through these issues with pregnant women about the issues around what would be the considerations in pregnancy for having the vaccination versus what would be the concerns if you're exposed to COVID in pregnancy. So this UK decision aid, many people have found quite helpful if they wish to communicate with pregnant women. So what's Australia and New Zealand's current advice? So Australia and New Zealand College of Obstetricians and Gynecologists are currently saying, and this is from 10th of March, so they are currently saying, although the available data do not indicate any safety concerns or harm to pregnancy, there is insufficient evidence to recommend routine use during pregnancy. However, if a pregnant woman meets the definition of being particularly vulnerable, she should discuss the option with her obstetrician, GP and midwife. So you can see that back in March, the New Zealand Australian College of Obstetricians and Gynecologists were more cautious. And the reason for that was really because we did not, and still do not, have COVID in the New Zealand community. So there was not such an urgency. So where have we got to? Well, our current advice in the New Zealand Immunisation Handbook, as under Chapter 5 of COVID disease, our current advice is that pregnancy remains a precaution for the mRNA vaccines. To date, previous clinical studies have not investigated the vaccine in pregnancy. Clinical trials are underway in the US. Based on how the vaccine works, it is unlikely to pose a specific risk when given to pregnant women. Increased risk of severe disease in pregnancy and adverse fetal outcomes has been documented. So the point is made that the disease is severe. It's recommended to delay vaccination until after delivery if the pregnant woman is at low risk of exposure. But for those at risk of exposure, vaccination can be offered with informed consent. So I think the problem for us with this language is what is low risk of exposure? One could argue, to be quite frank, that New Zealand is at risk of exposure. The only reason we are managing not to be at risk of exposure is because we have our borders closed. So the current recommendation is routine testing for pregnancy before vaccination is not recommended. Women who are trying to become pregnant do not need to avoid pregnancy after receiving the vaccination. That's where our advice stands. Now, the current advice is being looked at as we speak, and it is going to be run again through the National Technical Advisory Group to consider whether we should be making a stronger recommendation in pregnancy in view of all the international recommendations and the international advice, which is all looking like these vaccines, as you would expect, are expected to be safe in pregnancy. Now, pregnant women are at higher risk of COVID-19 disease. So they are listed in New Zealand's Category 3 to be offered COVID vaccine in the Category 3 rollout. So at the moment, the advice is pregnant women are at higher risk of COVID. They can be offered the vaccine. And so certainly for someone who's at risk of exposure, such as a frontline healthcare provider, a member of an MIQ or border staff, one would offer the vaccine without concern. For women who are not in that position, one could argue they may still prefer to wait until their infant was born, as they're less likely to be at risk. So how do you add up your vaccination decisions in pregnancy? Well, firstly, there are no potential safety concerns that are coming up through this very big amount of data that is now coming through. Post-licensure data is very reassuring. Most countries are at high risk of COVID disease, and now, as you can see, they are all generally recommending vaccinating pregnant women. The other important point is that vaccination in pregnancy with these vaccines does give antibody protection. So if you vaccinate a pregnant woman, they do get an antibody response to the vaccine. The antibody then is passively transferred to the infant. So the fetus and the newborn infant will have passive antibody protection. So that's an important plus about going ahead with vaccination. And it's important for people to be aware that also when you're breastfeeding, that you will also pass on protective antibodies to your infant. The other interesting point that's worth noticing is the immune response to the vaccine is more effective than to the COVID disease itself. Breastfeeding, should we be vaccinating breastfeeding women? The answer is absolutely yes. There is no concern about giving a vaccine to a pregnant woman, to a breastfeeding woman. There is no plausible reason for any safety concern. The mRNA template is broken down very quickly. If there was any possible fat lipid coat left over in the breast milk, if it did come through the breast milk, it would be broken down in the infant GI tract. Not that you'd be worried about a nanoparticle lipid anyway. The other advantage of breastfeeding is that the infant will get antibody protection from the breast milk, which is a huge plus. So vaccination while breastfeeding provides protective antibodies for the infant. So Chapter 5.5 of the New Zealand Handbook recommends that while lactating, breastfeeding women were not included in phase 3 studies, as with all our scheduled vaccines, there are no safety concerns about giving this vaccine to breastfeeding women. Now, separate topic, there is a conversation that's come up about mammography and vaccination. Now, interestingly, there has been known for a long time that when you give a vaccine, in rare cases, you can get lymphadenopathy at the local site from where the vaccine was given. Now, this makes total sense because if you give a vaccine into an arm and you get a good, strong local reaction, it will go to the local lymphatic system, which is under the arm. So it's perfectly reasonable and not at all unexpected that you will get an immune response in the local lymphatic system. Now, in very rare cases, you can get lymphadenopathy. This has been reported after BCG, after flu, and after HPV vaccines. Most of these reactions settle within a few days, but there is the theoretical potential that you could still have lymphadenopathy for up to 6 weeks. Now, I actually find this quite interesting because when I had my first Pfizer vaccine, I actually got an ache in my armpit and, it was just a low-grade ache and I couldn't feel any lymphadenopathy, but it was clear to me that there was a local lymphatic system response going on. And in a way, I felt quite good about that. I felt, well, that means my vaccine's working quite well. And it was there for probably just a day and it went away. So there is a theoretical issue that you could get lymphadenopathy under the arm. Now, that's neither here nor there because it settles down. So it's not a problem. However, the only concern you might have is if somebody had a mammogram soon after the vaccine and when they looked at the mammogram, they saw unilateral lymphadenopathy. That would be the only point of concern. So I note there that there's a study reported in the States where the mRNA vaccines, they did see axillary swelling and tenderness and in about 11% of patients after the Moderna and about 16% after dose 2. Notice that there's quite an incidence after the placebo as well. So a lot of people, it's quite common to have enlargement of your lymph nodes temporarily. After any respiratory illness or any other illness, you can get enlargement of lymph nodes. Now, to date, they didn't see that within the Pfizer RCT, but it wasn't specifically asked for. So at this stage, there's just been occasional case reports of this. So this is a rare theoretical possibility. So what's the New Zealand advice? Well, basically carry on, okay? Just be aware of this, but carry on. Do not delay your mammogram. Do not delay your COVID vaccine. But if you do attend a mammogram, it's recommended that you mention to the radiographer that you've had a COVID vaccine recently. Unlikely to be a problem, just worth noticing. So we say in the New Zealand advice, this is because occasionally the vaccine can cause swelling of the lymph nodes in the armpit near the injection site. This usually settles a few days after vaccination, but may be detectable on a mammogram for up to a few weeks. So do not delay vaccination, do not delay mammography, but just be aware this is a rare possibility. Now that's really most of what I was going to say. I was going to touch on a couple of issues that come up, and in particular, this issue of fertility. Could a COVID vaccine affect fertility? Now, there's a bit of a myth out there that is a bit of a misunderstanding around COVID and how it works, but there is no biological, plausible reason why this vaccine could have any effect on our genes or fertility. And there's just a little summary there again of how the mRNA vaccine works. So you're injecting a code, it's taken up at the injection site in the arm. It's these instructions that make the proteins that create the immune response. So there is no concern about vaccines and fertility. There's some data from the animal studies very early on in the study showing no effect on fertility. And in the clinical trials, accidental pregnancies did occur. And so these accidentals were all pregnancies were followed up and they were spread equally across the vaccinated and the non-vaccinated groups. So there's no evidence from the accidental pregnancies that vaccine is stopping you fall pregnant. And these pregnancies were all followed up and there were no concerns found. So there really does not appear to be any concern about fertility. There is a bit of a myth about the spike protein and the receptor site. A myth was created that it was similar to a receptor site in the placenta. This is not correct. They are not similar. And also, even if they were similar, you would then expect to see an increased incidence of miscarriage. And we are definitely not seeing an increased incidence of miscarriage. So that's a summary of my data around these issues. I'm now going to stop sharing my screen and let's see if people have got some other questions or comments that they'd like to ask. Anything at all, really. We can open this up to anything around COVID vaccines. I think we've got one question in the chat. Looking pretty good.
Sorry, Nikki. Right, yeah, no questions come through yet. So now's an opportunity for people to type them in if they have got a particular question for Nikki. We're lucky to have her with us this evening. But at the moment, you seem to have answered everybody's questions with your presentation.
I think it's really useful, Nikki.
What I would say to people is that our advice has been a bit difficult for pregnant women to interpret, because what we're saying is all the data is looking like it's safe. However, if you want to delay, that's fine. Now, it is a slightly ambiguous statement, and I think that is quite difficult for pregnant women to get their heads around. And I think personally, as looking at the data we've got, particularly coming through on the large American databases, and knowing from first principles that all these vaccines are not expected to be unsafe, I feel very confident about supporting the recommendation to give to pregnant women. But equally, if a woman chooses to delay in the New Zealand context currently, that's totally fine. There's no reason why not. I'd be a little worried about people in early pregnancy now that you've still got 9 months to go. And if we do start opening up the borders a bit more, if we did get COVID cases coming in, I think we'd have to shift our advice and make it a bit stronger. But at this stage, if a pregnant woman wants to delay and she's not a frontline healthcare provider or at risk of being exposed, then, you know, it is perfectly reasonable at this point.
Right, there's somebody asking here how this information will be shared, and I should have said at the beginning that these webinars are recorded and they will go onto our website, so people on the COVID vaccine website, so you will be able to access them there as and when you want, or direct your friends to them. We've also got somebody who's saying that in regards to your comment about post-vaccine lymphadenopathy, they've seen this rare complication with Hep A vaccine and travel vaccines before as well.
Yeah, no, thanks for that. I mean, I would expect that with any decent vaccine that has a good immune response, that you are going to occasionally see lymphadenopathy, because that's exactly how the vaccine's working. It's going to the local site of the lymph nodes. So occasionally they will be big enough to pick up. And of course, we'll pick more up on mammography than when you would just pick up by feeling them. And I suspect the more women we ask, the more people would notice, like I did, that you can feel a bit uncomfortable in the axilla sometimes after you've had a vaccine.
There's a question here around vaccination technique, and the person had noticed a large blob, they say, of injection of the actual vaccine on the site. Now, actually, that actually does occur sometimes, and the person is concerned they didn't get the full dose. The thing I can say about that is that if you actually look at immunisation technique, you want to be placing the needle in, and you place the needle in and then you start plunging. So sometimes you'll see people, they actually hold the syringe with their thumb on the syringe. So what tends to happen is they'll be putting pressure in. So put the needle in, then start to give it. And don't really push hard and fast, because it will just track back out onto the skin. So you want a really nice steady approach. Finish plunging to the end of, you know, the syringe, then take your needle out, and hopefully you won't see vaccine coming back out onto the skin. So usually that occurs when the person has either been sort of plunging and pulling out at the same time, or plunging the needle too fast and you get it backtracking.
What I would say to that one is absolutely backing what you've said, Loretta, but also an element of reassurance. There is a small safety margin. So if a little bit of vaccine doesn't go in, it doesn't mean that the vaccine won't have been effective. So for that individual, there's reassurance there. But obviously, best practice, we want all the vaccine to go into our consumers or our clients or customers or whatever we're going to call them every time. So best practice, but equally reassurance that that vaccine will still have been effective, even if there was a little bit of it lost. Right, we've answered that one. So questions seem to have dried up at the moment. No, think if there's no more questions, we thank everybody for spending the time with us this evening. I'm sure you've got other things you need to be getting on with. And thank you very much, Nikki. I'm sure there will be a lot of people that will watch this webinar at a later stage.
And thanks to everybody out there. Kia kaha to all and all the best. And we'll see how we go over the next few months.
Yeah, and thanks for all the work you're putting in. We appreciate it. Kia ora. Bye.
Thanks.